When my surgeon told me I was choosing quality of life over hormones, I knew she was wrong. My oncologist did not try to dissuade me, she just documented my decision in her chart note. That's one reason I'm so passionate about bringing the right information to you. I'm Dr. Mana, your friend and functional medicine doctor, and it's my pleasure to bring this episode to you on what the Menopause Society gets right and wrong about hormones today. Hormones are one of the hottest topics in women's health today, and yet the misinformation and controversies still abound. When it comes to navigating hormone therapy during menopause, the science seems to be constantly evolving. So, the Menopause Society issued a comprehensive position statement in 2022 that offers clear, evidence-based guidance for both women and healthcare practitioners. Here's what you need to know, broken down into simple, straightforward categories. Number one, the Menopause Society's position on why hormone therapy matters. It matters because it is still the most effective treatment for two of the most common and disruptive menopausal symptoms, hot flashes and night sweats, otherwise known as vasomotor symptoms. Vaginal dryness, pain with sex, and urinary discomfort, which is technically called the genitourinary syndrome of menopause. All of these symptoms are helped immensely by hormone therapy. Hormones also play a crucial role in preventing bone loss and reducing fracture risk, especially in the early years after menopause. So, my verdict on all of that information is that it's correct. I agree with all of that, and this is very helpful information to get out to all the women out there. Number two, personalization is key. There is no one-size-fits-all approach. Hormone therapy decisions should be made together with your healthcare provider and reevaluated regularly. The goal is to find the lowest effective dose, the right form, whether it's a pill, a patch, gel, or vaginal, the right duration, the right time to start based on your symptoms and health history. That's what the Menopause Society says. So my verdict on this, or my viewpoint on this is, yes, personalization is absolutely key. I do question this point about the lowest effective dose. So, a low amount of estrogen can help to treat hot flashes and night sweats. But is it the same amount that's also optimal for bone benefits, brain, or heart benefits? In my experience, the term lowest effective dose is misleading, can cause women to be underdosed, and also kind of perpetuates this thing about that hormones are in some way dangerous, so you should use the lowest effective dose. My perspective is you should use the right dose that gets you the comfort in the vulvovaginal area, that rebuilds your bone, that keeps your brain sharp, and of course helps you with your hot flashes, night sweats, sleep, and all the other benefits. So I'm not a fan of the term lowest effective dose. Number three, timing matters. The Menopause Society states that hormone therapy is generally safest and most beneficial when started before the age of 60 or within 10 years of the onset of menopause. In these cases, the benefits of treatment often outweigh the risks. My perspective on this caveat comes from the poorly conducted WHI or Women's Health Initiative study, which showed HRT benefits for women in the age group of 50 to 59. The study showed a small increase in cancer and blood clots for older women. But here is the real goal. You have to dig deeper. Why did the older women show health risks? Because the women were unhealthy to start with. Many of them had multiple diagnoses of different illnesses already, were obese, and the hormones used were not bioidentical. In that study, we used conjugated equine estrogens, which are horse estrogens, and synthetic progesterone. We did not use bioidentical hormones. So an article in The Lancet, which is a very highly regarded magazine in the world of science and medicine, This magazine published in 2024, an article published in this magazine in 2024 argues it is time to retire the caveat of starting hormone therapy within 10 years of onset of menopause. I recommend starting bioidentical hormone therapy as soon as possible, of course, during perimenopause. Because that's when you begin to have these symptoms that affect your quality of life in a deep way. Or the other time is to start right at the beginning of menopause. However, by denying older women who are more than 10 years out from menopause, we do them a huge disservice. In my clinical practice, I have older women that were not on hormones for 20 years or more. I started them on hormones. We started low and slow. And within 6 to 9 months of being on hormones, they are doing so well that I feel it's a huge disservice to keep older women from doing a trial of 3 to 6 months of hormones and see how they feel. And of course, we can do it with all kinds of precautions in place. If we need to have ultrasounds or regular checks, we can do that. But blanketly denying older women hormone therapy, bioidentical hormone therapy, is not the right thing. Number 4, route of administration makes a difference. So, choosing how hormones are delivered matters for risk. Transdermal therapy, which are patches and gels that you apply on the skin, so the Menopause Society says they may reduce the risk of blood clots and stroke. And they also say that lower doses are also associated with fewer risks. So my perspective on this is that yes, transdermal therapy is better than oral, especially for estrogen. As I mentioned already, the WHI study used oral or synthetic hormones, which do not have the best risk or safety profile. Again, I do not agree with lower doses being associated with fewer risks. The dose needs to be individualized for each woman, and this is where we need a lot more research, but there's plenty of clinical data that I have and other practitioners have, which show that it's not the lowest dose that's the most helpful, it's the right dose that's the most helpful. Moving on, number 5. What does the Menopause Society have to say about women with early or premature menopause? Women who enter menopause early, before age 40, or have something called primary ovarian insufficiency, POI, they face higher risks of bone loss, heart disease, cognitive decline. For these women, hormone therapy is often recommended until the average age of menopause, which is about 51, unless there is a medical reason not to use it. So this is very, very important to understand. I agree that hormone therapy is extremely beneficial in preventing bone loss, heart disease, and cognitive decline. And certainly, if younger women have their ovaries removed or dysfunctional due to any reason, they need to have their hormone deficit remedied. But I believe the same applies to older women. In my clinic, as I mentioned already, the older women that have been diagnosed with things like mild cognitive impairment in their 70s started HRT doing really well. Number 6. Hormone therapy after age 60. There is limited data from clinical trials on using hormone therapy beyond age 60 or 65. However, it doesn't have to be automatically stopped. It may still be used for ongoing symptoms like hot flashes or vaginal dryness. It may also be considered for osteoporosis prevention after weighing risks and benefits with your doctor. So, here's my opinion. There is limited data from clinical trials because the most well-funded trial was not done right. There is no need to discontinue HRT if you've been taking it for a while and are feeling well, unless something is happening which makes you question that something is wrong. If there is uncontrolled vaginal bleeding, if there is unremitting breast tenderness, if there is a lump in the breast, of course, it's time to go see a doctor and make sure that all the information, all your symptoms are taken into consideration, or your quality of life is taken into consideration, and all the correct diagnostics are done. I do recommend my patients to do a DEXA scan, a bone density scan, before they begin hormone therapy, and then again a year or two afterwards, and we always end up seeing an improvement. Number 7, vaginal estrogen for vulvovaginal atrophy or genital urinary syndrome of menopause. And the Menopause Society says that this is safe at any age. Low-dose vaginal estrogen or non-estrogen alternatives can be used at any age and for as long as needed to relieve symptoms of GSM, genital urinary syndrome of menopause. Even some breast and endometrial cancer survivors may benefit if non-hormonal therapies haven't worked. My opinion on this. I agree, but I will go a step further. If a woman with a history of breast cancer has any vulvovaginal discomfort, I reach for vaginal estrogen or DHEA right away. The relief is quick and lasts as long as the therapy is used. In my experience, lubes and gels are often insufficient. There is a non-hormonal prescription, a selective estrogen receptor modulator that may be worth considering if desired. Number 8. What about breast cancer risk? So the Menopause Society says the short-term use of estrogen with progestogen doesn't significantly raise the risk. Estrogen alone may even lower breast cancer risk, and risk may increase with long-term use, especially after age 60 to 65, but observational data suggests that the risk is rare. So, here's my thought on that. When the Menopause Society uses the word progestogen, that is not natural progesterone. It also includes synthetic progestin, and I don't want to muddy the waters. I do not prescribe synthetic progestin or medroxyprogesterone acetate when we have bioidentical hormone replacement therapy easily available at most pharmacies and is covered by most insurance. Why would we use oral estrogen or conjugated equine estrogens and medroxyprogesterone acetate or another synthetic progestin when we have better options available? Even though the increasing adverse events, breast cancer, blood clots, in the WHI trial was small, why take any risk with doing synthetic hormones? For this risk, I prescribe only bioidentical hormones. Number 9. Concerns with compounded bioidentical hormones. While many women seek natural alternatives, compounded bioidentical hormone therapies raise red flags because they are not well regulated. They may contain inconsistent doses, they may lack purity or sterility, and they do not carry standardized risk labeling. And they lack strong evidence for safety and effectiveness. And the Menopause Society says always ask whether a therapy is FDA approved. So my experience on that point, my opinion, that it is true that compounded hormone formulations are not approved by the FDA. Therefore, it is important to work with an ethical and well-qualified pharmacist and an accredited compounding pharmacy which does frequent third-party testing. I use a compounding pharmacy that has been around for decades. I know the pharmacist to be a very ethical individual, and many of my patients have been happy for a long time. Not to mention that his prices are very competitive, which means lower than many other pharmacies. So yes, you have to be careful with compounding pharmacies, and perhaps there is a case to be made for some sort of regulation, but to say that compounding pharmacies are unreliable or unethical or something, you're likely to be duped by them, I don't really agree with that. Number 10. The bottom line. So, the Menopause Society says that hormone therapy is a safe and effective option for many women, especially when started at the right time and used under proper medical supervision. It can improve your quality of life, ease your symptoms, prevent long-term health risks like bone loss, and the key is personalized care and ongoing conversations with a provider who truly understands the unique challenges and changes during midlife. And I agree with that. It is important to work with a practitioner who understands your particular situation and is willing to work with you to see what is the best dosing schedule for you and work with you over a period of time. So if you have questions about whether hormone therapy is right for you, you are welcome to schedule a consultation to discuss your goals, your symptoms, and your concerns. If you want to take an inventory of your perimenopause or menopause symptoms, take the menopause quiz here. I'm Dr. Manan, your friend and functional medicine doctor, and I will see you in the next episode.